Okay. Well, welcome. Thank you for joining me, ladies. Um, for anybody who is catching up afterwards on the recording, or for anyone outside of our community who may not know, my name is Courtney. I am the director of Tapestries, which is our memory support community here at United Methodist Communities of Pittman. I have a lot of background, so I'm a social worker, and I have a lot of background in brain injury and mental health and senior care. So just a lot of things connected to the brain that I hope to be able to use to help pass on some information to you. So today we're talking about how dementia and pain kind of intersect. And it's kind of a strange thing, believe it or not. Until relatively recently, even doctors and scientists and experts believed that people with dementia couldn't feel pain, that it was part of what they lost when the dementia set in. And because of that, they tend to be underserved when it comes to pain treatment, which is terrible because, just because they can't communicate their discomfort doesn't mean they aren't feeling it. So we're going to talk a lot today about the different ways that pain looks for someone with dementia, and then how you can be better at recognizing it for your loved ones so that you can help advocate for them to get the treatment that they need, whether that's with us or with a doctor, or just, when they're with you, at home, if something seems not right, that kind of thing. So first, we're going to start with the problems with pain. Aside from the fact that it hurts, which is obviously like the number one issue, but pain negatively impacts cognition. So for our loved ones with dementia, they get even more confused when something isn't feeling right, when they're uncomfortable. And you can think about that even for yourself. Like if you think to the last time you were in a lot of pain, maybe you had a migraine, maybe you had surgery, something to that effect. Were you thinking clearly? Would you have been able to do a complex task while you were feeling that particular way?
Right.
Because I know I can't. So we really shouldn't be surprised when we see our loved ones get even more confused and even more kind of disoriented when they're not feeling quite right. The next thing is that pain is very personal, and the person who's experiencing the pain is the perspective that we most need to help understand what's happening so that we can fix it. And for a person with dementia, that becomes very complicated. Something that's kind of interesting and unusual is that statistically speaking, family members tend to overestimate the amount of pain that their loved one is experiencing. So if you as a loved one were up to deciding on a course of medication treatment, you would probably overdose your loved one just because you're so concerned about how they're feeling. You want to make sure they're comfortable and are more likely to overdo it. Whereas providers, doctors, professionals are more likely to undermine the amount of pain statistically and to undertreat it, which is, of course, a big problem, especially, as I said, when until relatively recently, even professionals believed that people with dementia couldn't feel pain. So that kind of leads into this next point, that the person with dementia may not be able to communicate their pain in a traditional way. When you or I are uncomfortable, we can say, hey, I've got a headache and I just can't do it today, that kind of thing. But they aren't always able to communicate that clearly. And sometimes they don't even understand themselves what they're feeling. We kind of can tell that it's pain because of the signs that we see, but they might not even know why they're uncomfortable, why they're different, why they are more confused or anything like that. And often it kind of presents in a different way because of that difficulty discerning what's going on. It also looks very different for different people. So I'm sure we all know somebody that's got like an incredibly high pain tolerance that you're just like, ugh, how do they do that? I know my niece, when she was little, she was maybe 4 or 5, and she got MRSA from a swimming pool, like a public swimming pool. And my sister didn't even know that she had it because she never complained about it until she had like a giant wound that was like a problem. because she just didn't feel it. It wasn't a problem for her, so she never mentioned it. And that's a little strange, because so when my sister subsequently got the MRSA infection from her, she couldn't tolerate the pain for even an hour. She was like, oh no, I'm going to the hospital. So, just everybody is different. But on top of that, we also all show it differently, especially for our loved ones who've had chronic pain, people who've had, back pain all their lives, or who've had arthritis for a long time. They tend to not show that they're feeling pain as much as someone who just gets, who just hurts now and then, because they're just better equipped at dealing with it, because they're dealing with it all the time and they can't let it get in the way of things. So there's a lot of like fine details that are specific to the person that make it hard to tell what's going on. But it definitely impacts our mood, our behavior, and our functioning, even without dementia in the mix. And all of that combined makes treatment complicated. And so treatment can be complicated, especially for our loved ones with dementia, because they respond differently to medications than, a healthy younger person with a healthy, normal brain would. Any thoughts, questions, anything like that on any of this?
No, I'm good. Thank you.
Okay. So before we get into like specifics that you should look like, this is just a kind of a general idea of what pain might look like. So the number one thing is an unexpected and unexplained change in mood or behavior. We all know that at times our loved ones with dementia can be a little bit unpredictable, but if this seems like a complete, 180 from how they normally are, we always want to consider pain as the first possible cause, because behavior is communication for all of us. Behavior is communication. And so when they're not able to communicate it in any other way, sometimes they act out or act strangely. So we definitely want to make sure that we're thinking of pain, that pain is at the forefront of our mind as to what might be going on here when we see a change like that. For some people, it might look like increased restlessness and like they're fidgety, they're pacing, that sort of thing. For other people, it might look like they're sleepy all the time. And that's kind of counterintuitive, because when you see someone sleeping, you think, oh, they look so peaceful, they look so comfortable, but they might be sleeping because that's the only way for them to escape what they're feeling. We may see pacing, we may see rummaging through things, kind of looking aimlessly through stuff, tearing through drawers, that sort of thing. Wandering, especially with that increased confusion that I mentioned, maybe wandering into places that they typically wouldn't go, that sort of thing. Searching for absent loved ones. This is a big one with pain, particularly looking for parents who've passed away. I know, like ever since we were kids, we're kind of raised that, mommy fixes boo-boos. So,
Yeah.
So often one of the first things we see is that if a person who's not normally doing this is looking for mom, it's probably a good sign that they're uncomfortable. So if that's out of the ordinary for your loved one, that's definitely something you want to consider. Self-soothing behaviors. And so I say here that this is a spectrum, and I mean like a wild one. Okay. So self-soothing behaviors for some people is going to look like snacking a lot more. When I'm uncomfortable, I want to eat cookies. They make me feel better. But for other people, self-soothing behaviors might look like stripping off all of their clothes in the middle of a room full of people. They might perceive that the clothing is what's making them uncomfortable, and they don't necessarily recognize that, nudity in public isn't appropriate anymore, and they'll just whip it right off. And you're like, oh my goodness. And everything in between. So basically anything that you might do to make you comfortable. I've seen people who go to the bathroom religiously, like will go to the bathroom, turn around and come out and go right back in as soon as they've finished just about. And it's almost like some part of their brain knows they're uncomfortable, but can't quite figure out why they're uncomfortable. And so they're just picking the obvious things. Let me eat, let me pee, let me, like that sort of stuff to try to figure out what it is. So it's really, I don't know how else to say it other than it's really a spectrum. So again, if you see any unusual changes, even if they seem kind of innocuous, like having extra snacks or going to the bathroom more, we might want to consider, like, is this that effort? Frequently touching or indicating a part of the body. I know we see a lot of residents that if we ask them if they're hurting, they'll say, no, I feel fine, but they just can't stop tugging, on that ear, or they can't stop rubbing that spot on their stomach. And then sure enough, if we look, that spot's inflamed, or, maybe the ear is clogged, that sort of thing. So that's definitely a good sign. Irritability, agitation, and even aggression. I mean, again, think about us when we're in pain. How pleasant are you to be around when you're uncomfortable? Some of us are probably better than others. But when you're really hurting, of course, you're going to be short-tempered. Of course, things are going to get on your nerves more easily. It is rare, but we do see people that will occasionally strike out, lash out, especially, for something like knee pain. If we're going in to change someone's clothes, removing and putting on new pants is a big problem for knee pain, because you've got to bend your feet and move around a lot to do that. We've definitely had instances where, you're helping somebody put on their pants and they wince and their reflex is to hit, because you're hurting me, and they don't necessarily realize that it's not intentional or that it's not something you've done on purpose. So that's just something to be mindful of. One, if your loved one is not typically aggressive and they are aggressive with you, this is almost certainly what's going on. But also for you to be able to protect yourself, because you don't both need to be in pain. So, and then of course, obvious signs of pain that would be for anyone. So if you see a cut, bleeding, things like that, we can assume safely that there's probably at least some degree of pain associated with it. Swelling, redness, rash, and irritation. If you are helping your loved one with showers and changing, toileting, things like that, when you have those opportunities, you might want to pay special attention to like the creases, the places where, where the sun doesn't shine, so to speak, because often those areas can get raw with trapped moisture and they may not be able to communicate it to you. But if you actually look in those skin folds, you might see that there's some clear signs that they're uncomfortable. So just something, to be on the lookout for. And so I have this road here, and the reason that it's there is because we want to remember that our loved ones can't necessarily tell us exactly what they're feeling. So one of the things that we've talked about a lot is the way that the brain changes with dementia, and as some tissue dies, the brain is still trying to find a new way around. So it's almost like, you say you're going to the grocery store and the route, you've got a straight, nice, direct route, makes perfect sense. But there's a detour. And so you can still get to the grocery store with the detour, but it becomes a much more convoluted path. You've got to make like 16 turns, and it's on the wrong side of the road now, and it's a whole mess. That's kind of what brain plasticity does. It finds a workaround, but it's not a direct one. And so that point A to point B of this doesn't feel so good, hey, my head hurts, isn't there. We start to see strange communication. So an example that comes readily to mind, we had a resident that every afternoon would start looking for a way out. I need to go home. I need to go home. And this resident was trying to walk to their home, which had previously been in Vineland. It's a pretty long walk. And so you wouldn't think that a person planning to walk, 20 miles, 30 miles is feeling pain. That seems like an action that would be somebody in pretty good shape. But what was actually happening, and this was a lot of trial and error to figure this out, but what was actually happening was that she was having foot pain, which is even worse to think of all that walking. And all she was thinking was, I need to get home to my bed. And the only way for me to get home to my bed is to walk. So even though my feet hurt, I need to walk home. And so as soon as we found out that that was what was going on, before she got to that point in the afternoon, we could take her to her bed to lay down so that she could take the pressure off of her feet. And then once she got a little nap, her feet got a break, she was okay for the rest of the day. And we stopped seeing that behavior. But you see, like, that's not an intuitive connection to draw. And so that's what that roadmap is there for. So we just have to think, if it seems really bizarre, maybe this is what's going on. And even if we're wrong, pain intervention can be something relatively safe that we can feel confident doing anyway. So if you do see an unexpected change in behavior, you might want to start with Tylenol. Tylenol or Advil or whatever works for your loved one. Start with it right out of the gate, and do it consistently for a few days, and see if that makes a change. And if it doesn't, no harm done. As long as you're adhering to the dosing schedule, it's a relatively safe course of action. You're not going to cause any permanent damage, or really any damage in most cases. But you may very well see that things change with something as simple as Tylenol. So it's just a really, it's a good first go-to when you're, like, I have no idea what else to do. Any thoughts or questions about any of that? No? Okay.
No, it all makes sense. Thank you.
Okay.
Yeah, that's a good way of helping me understand it.
Yeah, it's because it's so like counter to the way that we think.
Right.
So it's definitely not something you would come up with on your own. And like I said, it's a lot of trial and error, and mostly error. So
Yeah.
good, just a good first course of action to keep in mind. Okay. So then a little more specifically, there are like things we can look for, things we can see to help determine whether our loved one is in pain. So I've got a little chart here, and this is taken pretty much directly from the assessment tool we use when we think that a resident might be in pain. It's called a pain ad. It's a pain assessment for advanced dementia. And you can find it along with a lot of other types of pain assessment tools for people with dementia online with a quick Google search. So if you think that your loved one might be going through something, you don't necessarily have to commit this to memory. You can do a quick Google search and, pain for people with dementia, and it should come right up. But we're looking at 5 main areas with this tool. So the first is breathing. The second is vocalization, so the sounds that they're making, facial expressions, body language, and consolability, which is basically just how easy is it to comfort them? How easy is it to change their behavior in that moment? So obviously, if our loved one is in good shape, breathing is going to be normal and comfortable. Their vocalization will be normal, like they can speak normally, whatever's normal for them, or they're quiet. They may be smiling, or they may just have a neutral expression. Their body language will be relaxed. And there's no need to console them. They're not upset. All other signs lead to, point to that things are okay. For breathing, some of the more mild signs of pain might be occasional labored breathing. So this is going to look like maybe a lot of sighing. Like just every few minutes, they're like, or like huffing and puffing, or, that sort of thing. It may be like that they're wheezing, or they may even tell you that they're short of breath, or there may be short periods of hyperventilation where you're looking at them and thinking their chest is rising awfully quickly, or they're breathing awfully hard. More moderate or more severe signs of pain associated with breathing would be if their breathing is noisy, like you can hear it across the room. It's consistently labored. They look like they're struggling to get air in. longer periods of hyperventilation, or irregular breathing. So there's a lot of ways, basically anything that's atypical of how your loved one breathes, which is probably not a thing you've ever actively paid attention to, but I guarantee you it's something you would notice if it was different. So you've probably never noticed how mom breathes, but part of you somewhere knows. And so when I say irregular breathing, it's basically anything that's different from their baseline. But the image that I kind of get in my head, and maybe this helps you, is like if you think of when you see someone who's like very deeply distraught and they're crying and they get that kind of hitch in their breath where it's like like that sort of thing, that's a great sign. That's not normal, that sort of thing. So we want to pay attention to, is their breathing consistent? Is it normal? Is it shallow? Is it rapid? Does it look comfortable? Does it seem labored? All of that stuff. So for vocalization, we could hear moaning and groaning, and it could again be those occasional like, especially with movement or effort. And they can also just generally be cranky. If your loved one is usually in a pleasant mood, when they're cranky, it's a good sign they're uncomfortable. Further than that, so the more moderate or severe symptoms are repeatedly calling out or troubled speech. So this is, I can't stop moaning and groaning. I can't stop shouting. Every time I move, it's like, like something like that. Or troubled speech. Maybe they're trying to carry on a conversation with you, but they just sound very distressed. And it may be about something obvious. It may be about something, strange. You might be talking about the weather or something completely innocuous, but they just sound worried. That could be a sign that something's going wrong. And crying, we definitely want to take seriously as a sign of pain, especially if that's not normal for our loved one. So for facial expression, if they look sad, if they're frowning, if they've got a serious expression on their face, or they look scared, things like that, that's not typical for them. And then more severe, if they're grimacing, if it looks like their facial expressions are not natural, not comfortable, and not controlled, like every now and then they're wincing or that sort of thing, or they're making a strained face where it obviously looks different than their baseline. That's going to be a good sign that they're feeling something. So the body language, if it's more mild, we might see that they just seem a little tense. Maybe they're they're moving a little slower than usual. We may see the opposite, that they're moving a lot compared to usual. They're fidgeting, they're pacing, they can't sit still. Maybe they're shifting in their seat a lot. They want to lay down, that sort of thing, because they're just trying to find a comfortable position and can't. More moderate to severe symptoms we might see, if somebody's really struggling, is like rigidness to their movement, especially like if the muscles are really tense and they don't want to move something. For people with arthritis pain, knees, shoulders, elbows, that sort of thing, if they're holding that arm really, really still, it's a good sign that it hurts. They don't want to move it because moving it hurts. Clenched fists, another great sign. Usually that they're trying to find some other like outlet to distract them from that pain. Contracted muscles, and this is think of like curling up into fetal position almost. So it might be that they've got their knees drawn into their chest, especially if they're laying down in bed. It might be that their arms are curled up really tight, or they just can't seem to relax their hands, like their fingers are balled up and they just can't seem to get them to loosen up, anything like that. So any kind of muscle contraction that's not normal for them. Either pulling away from you or pushing you away in a way that's not normal for them. So if maybe it's just that physical contact is too painful, or maybe they're afraid you're going to move them in a way that's uncomfortable. So they may push or pull away from you, that sort of thing. And again, striking out. If they're hitting you and that's not normal for them, that's definitely a sign that something is up. And especially, like I mentioned with our, with knee pain, things like that, care, while you're doing care, while you're helping your loved one with taking care of themselves is often where we see that. So putting on clothes requires a lot of movement. That's a great place to identify, arthritis pain, joint pain, muscle pain. You might be helping them brush their teeth and notice tooth sensitivity if they're brushing their teeth and suddenly they're really angry about it. It might be that the water's too cold. It might be that they've, got a cavity or, something like that. So they're feeling a lot of tooth sensitivity. So especially while you're helping your loved one with those care tasks, this is something that you want to be looking out for. And then for that consolability, for more mild pain, it might be that they're able to be distracted or they're able to be reassured with voice or touch. So if your loved one seems distressed, seems uncomfortable, but if you can keep them talking, they're good. That could be a sign that they've got mild pain, but that they don't necessarily need, a more serious treatment for it. Think about for yourself, you might have a mild nagging headache that you can go about your day with and try to ignore, but you might not be able to. And so then that's the worst end of the spectrum for consolability. If nothing seems to change how upset they seem, they aren't able to be distracted, they're just stuck on whatever the thing they're stuck on is, whether they're laying in bed or whether they're trying to, walk home, like the lady in my example. They just don't want to be reassured. Maybe the more you try to comfort them, the more argumentative they get. Anything like that is a sign that that they may be in pain. And so one cool thing that you can do with this tool, I think, are we all familiar with the 1 to 10 pain scale that you get when you go to the doctor and it's got the little faces?
Yeah.
Okay.
I've seen that.
So if you've ever seen that, that's a pretty standard way to measure pain on a scale of 1 to 10. So with this tool, if you consider everything in this symptom-free category to be one point, you consider everything in this to be 0 points. Symptom-free is 0 points because 0 is an option for no pain. Everything in this mild symptoms category is 1 point, and everything in this moderate to severe symptoms category is 2 points. And if you kind of add those up, what you're seeing, you'll get a 1 to 10 score. So maybe your loved one is breathing normally, but they're really cranky and their face is just like contorted, like they're grimacing. They seem a little tense and they're pacing a lot, but you can talk to them. So breathing is normal, that's a 0. They're cranky, that's 1. Grimacing makes that 3. Tense makes that 4. But able to be distracted makes that 5. So that's like a moderate level of pain. So so if that helps you think about, okay, this is what I'm seeing, how serious is it? That's just something you can keep in mind to help you guide what your next step is going to be for your loved one. Any questions about any of this?
No.
No, I'm good.
Okay. So then when we're looking at actually fixing the pain, so now we've figured out this is what's going on. How do we fix it? We want to consider the history of our loved one's pain and the history of their treatment. You're going to be probably the experts on this a lot of times. So if mom has always had chronic migraines, mom has always had chronic back pain, or she's had it for the last 20 years of her life, safe to assume that's what's going on. So if we know there's a history of certain pain, maybe they got occasional, like occasional muscle soreness with overuse kind of a thing. And so it wasn't regular, but it happened every now and then, something like that. You've probably taken notice of it over the years. And hopefully you have an idea of what's worked for them in the past. So, if mom always had her trusty bottle of Tylenol in her purse, it's a pretty safe assumption that Tylenol worked for her. If she was an ibuprofen girl, that's probably your best route. So we want to look at what's worked for them before, because if it used to work, odds are good it still works. And that's true of non-medication interventions too. Like maybe they just do well with rest. Maybe they do well with ice or with a heating pad, that sort of thing. So then the next thing we want to consider is what type of pain, because that's going to guide our interventions too. So for something chronic, where they feel that pain every day, we're probably going to approach that differently than the once in a while headache or the once in a while body ache. We might have, make sure that they always have medicine available to them for that chronic pain that they're always dealing with. We also want to consider, is this like surface level pain? Is this bone pain? Is this joint pain? Is this nerve pain? Because different treatments are going to work for different things. So Tylenol, not great for swelling. So if your loved one has a twisted ankle and their leg is swollen, Tylenol is probably not the best course of action. You're going to want something probably like an NSAID, like an Advil, an ibuprofen, that sort of thing. Those things, Advil, ibuprofen, are not great for nerve pain, and they're not great for bone pain. So if your loved one has like osteoarthritis, where it's bone on bone contact, that Advil is not going to cut it. We need to go a different route, kind of a thing. And same goes for nerve pain. So if maybe they've got diabetic neuropathy, something like that, where they get the tingling pins and needles, my body is on fire feeling in their feet and legs, that sort of thing, that takes a different kind of medication. So we always want to make sure that we're thinking about what kind of pain, if we know, and what treatment is appropriate for that kind of pain, because we definitely don't want to be pumping them full of a medication that's not helping. No, none of us want to take unnecessary medication, but for seniors, and particularly for seniors with dementia, the extra medication is never a good thing. So, so just something to be aware of. We want to consider both medication and non-medication related options. So non-medication related options, like I said, might be rest, might be a heating pad, might be an ice pack, might be massage, might be a warm bath, might be a favorite teddy bear or something like that they can cuddle with. There's all kinds of things that bring people comfort. It doesn't always have to be a medication intervention. If it is going to be a medication intervention, as I said, we want to consider what works for the person, what works for the type of pain they're experiencing, and how severe the pain is and what strength that medication is, because we want to make sure that it matches, that we're not overdoing it, but that we're also not underdoing it and doing them a disservice. We want to think about environmental and personal factors. So when I say environmental factors, I mean things going on around them that might be contributing to their pain. So with a headache, this might be the fluorescent lighting. It might be that there's a lot of activity going on and there's a lot of noise. With body aches, it might be that they wanted to do exercise. We're doing group exercise like we do every morning, and they want to do it, but today it just hurts too bad. And they don't necessarily recognize that that's what the problem is. So it might be an environmental thing. It may also be a personal factor, something going on with them in their, in their head or in their heart. Think about ourselves. We have different pain tolerance at different times. There are days when you walk off a paper cut and it's no big deal. There are days when a paper cut is the worst thing that's ever happened to you. It also can depend on the situation or the type of pain. I know logically that there are many worse things that can happen to you than stubbing your toe. But when you stub your toe, it is the worst thing that has ever happened in the world, and so just that kind of thing, like keeping in mind those personal factors that we may not be able to see, but that are always there. So the better we know the person, the easier it gets in determining that. We want to think about changes to routine, and this goes both ways. So we might want to think about, have there been any changes to their routine that may have contributed to their pain? We also want to think about, do we need to change their routine to adjust their pain? So it could be a cause, but it could also be a solution. Again, that might depend on the situation. For a person with rheumatic arthritis, where it's just that the joints get stiff and sore, movement is good. Movement is a great treatment for that, because a body in motion stays in motion. So the more we move, the better the joints loosen up, the easier things get. We might want to incorporate some daily exercises into our loved one's routine. Again, for that person with osteoarthritis, where their joints are completely gone and it's bone on bone in those shoulders, elbows, knees, wrists, ankles, whatever, exercise is the enemy. It's going to put them in unbearable pain. And so if they're doing exercise routinely, we need to find out something else for them to do to get that same feeling of, being productive and being involved, but without that detriment to their body. Or we might want to find other ways to modify the exercises to better suit their needs. So things like that, changes to routine, either to support their pain and getting better, or to reduce whatever's triggering pain. This is a big one for our loved ones with dementia. We have to consider what my loved one is willing to do. This is often the trickiest part of treating pain. So like I said, often one of the first signs we notice in people when they're uncomfortable is that they're irritable, they're angry, they're maybe a little more guarded or even a little more paranoid than usual. They don't want to take pills from us. So we might know that they're hurting, but if they're not going to take that Tylenol, it's not going to do them any good. So we might have to take a different approach until they get to a point where they're comfortable enough to be trusting again to receive to receive what they need. Your loved one may flat out refuse. We know that exercise is good for certain types of pain. We know that exercise is great for chronic back pain in most cases. But if your loved one is not going to do it, we can't force them to. So we want to make sure that we're thinking about, what are they willing to do and how do we work around that comfort level? If they're not willing to exercise, then maybe we go more of a heat and icing kind of route. If they're always cold and they're going to lose it at the moment we introduce an ice pack's not going to work. We need a new plan. Maybe we do a cold compress. Maybe we take another route altogether. Yeah. So it's tricky, but we want to help them, but we want to do it in a way that respects their wishes. And so that's kind of the hard part. So we want to definitely consider what they're willing to do. What can we help them with that isn't going to make a fight, basically. And then the last piece is consistency in treatment compared to as needed treatment. So there's definitely a time and a place for both. You don't want to take you don't want to take Imodium every day because you might get diarrhea. You don't want to take an Aleve every day because you might get a headache. It's, that's kind of silly. Those are things that you can address in the moment. But for other things, we want to make sure that treatment is consistent. So again, something like chronic pain, we know there's arthritis pain, we know there's back pain, knee pain, we know that they frequently get urinary tract infections, and so there might be kidney pain, like that sort of thing. If we know those are problems, we're going to pursue a different approach to the as needed thing. And we want to make sure that we stay on top of it, because it is far easier to help a person maintain comfort than it is to get them back to comfort at the point that pain is escalated. So something like missing a dose of medication can be a big deal, because it might mean that the next time they do get it, it's not as effective because they're in more pain at that point. So for something that we know is going on, we want to make sure that we're very consistent in how often they're getting that treatment. We want to be ahead of the pain rather than behind it and playing catch up, because it's just not as effective. And so for in those situations, like we talked about in the very beginning, where we may not know there's pain, we just see that the behavior is really funky. That's one of those times where we're going to take something like a Tylenol or an Advil or an ibuprofen and just give it consistently for a week, because again, it's not going to harm them, but we may see that it helps. And if it helps, bonus, that tells us, yep, we were right, it's pain, and now we can make a plan. And it may be a short-term thing. And so giving it for a week gives us an opportunity to get it under control and keep it under control. And hopefully that's enough time for the person's body to rest and recover and heal from whatever the problem is. If after stopping that treatment, we see that the problem starts to come back, we know that this is something that we need to address more seriously, kind of a thing. And we also know if we're treating it consistently with the Tylenol, Advil, whatever, and the behavior doesn't change, okay, different track, so we're kind of always looking at what's happening, what can I try, what works, what doesn't work, and then trying something new. That's kind of always the game plan. And I just had something else to say that slipped off the edge of my brain. Hopefully it comes back. Any thoughts, questions, concerns about any of this?
Nope.
Okay.
No, I'm good.
Okay. And so then the last thing that I want to touch on today is common concerns related to pain and treatment for our loved ones with dementia. So all of this is coming from things I hear from families, every day. This is coming from the problems we most consistently see. Oh, I did remember, but fortunately I address it on this slide, so never mind. So, it was about monitoring for efficacy, so we'll get there in just a moment. So one of the major concerns is medication side effects. Pain medications, especially the stronger the pain medication gets, usually the worse the side effects are. Tylenol taken consistently can have a not so positive impact on your liver. Aspirin and Advil taken consistently can have a not so positive impact on your kidneys. Pain medications, the stronger pain medications, like your oxycodones, your Percocets, things like that, can have a lot of unpleasant side effects. They cause constipation, they cause itching, they can, they cause drowsiness and sedation, they can cause increased confusion. So there's a lot of stuff that goes on. And one of the big things that we worry about, especially with those stronger medications, is fall risk. How is this going to impact how our loved one thinks about how they navigate and how they're physically able to navigate? So if this is making them even more confused, the pain is making them more confused, the medication is also making them more confused, they might not realize they have to take the blanket off before they get out of bed, and then they're in danger because they're going to trip on the blanket. If it on top of that is also making them dizzy, that's obviously a big problem. So when we think about medication side effects, we want to make sure that the medication is appropriate. We want to make sure that the dose is correct. And we want to think about, can we mitigate some of those risks with things like scheduling? So for those stronger pain medications, we might want to start by giving them at bedtime. It's going to help them sleep through the pain, which is a good thing, and their body is better able to recover if their pain is reduced and they're able to get a good night's rest. So that's a double win. And if it does create that fall risk, better to have it happen at night at a time when they're less mobile, they're less likely to get up, because hopefully they're sleeping through the night. So things like that. Your situation might be different. You might want to give your loved one that medication at a time when you're going to be there to monitor it, and night is not ideal. So if you bring them home, say for a holiday weekend, and they're hurting, you want to give it in the morning because you're afraid you might not wake up and hear them, if they fall at night. That's a different thing. So it's going to depend on what's you know, what's going on and what's best for the situation that you're in. But we can tweak dosing and scheduling of medications to try to help mitigate the risk of some of those side effects. Sometimes we need to add other medicines to help the side effects. So like if something like an oxycodone or even a morphine for our loved ones that are in like really severe pain or in like end of life stages, if they're really constipated, but that medication is necessary, we might have to add a Miralax or something like that to help combat those side effects. And that's also an option too, although we don't want to prescribe medication for our medication, but at times when it's unnecessary, it is definitely an option. So then we also want to think about potential tolerance or addiction issues. This is something that I hear from a lot of families. And so the first thing I want to say is if your loved one has never struggled with tolerance or addiction, you probably don't need to worry about this. Realistically, if they've made it this far in their lives without developing an addiction, odds are good they're not going to now. And particularly if they're in a care environment like here, where their medications are locked up and being administered, on a particular schedule, it's not really possible to get addicted. Certainly possible to build a tolerance because, that's just a side effect of taking medication consistently for some people. But the negative consequences of addiction, like taking too many pills, fear of overdose, running out of your prescriptions before it's early, or before it's due, all of that stuff, not really an issue when the medication is closely controlled like it would be in a setting like this. So as a general rule, I would say don't worry about the tolerance. Don't worry about the addiction because the system in place already prevents that for the vast majority of people. And obviously, if your loved one has history of addiction, or if they do build tolerance to pain medications rapidly, those are things you're going to want to communicate with about, make sure that you're advocating on their behalf. So if they build tolerance to medication quickly, you might need to get them on a progressive dose schedule where the dose is going up incrementally to deal with the pain. If it's ongoing over a long period of time, you might want to talk to the doctor about whether it's feasible to switch medications every so often to prevent that from happening. And of course, if there is addiction history, we want to avoid medications that are specific to the addiction. But again, the doctor can guide you through what alternatives are out there and what other treatments might be available. So then for that monitoring for efficacy piece, we're going to come back and use those same observational skills that we used to figure out that our loved one was in pain. So that same chart where I said, this is the sign that everything is good and normal. This is the sign that there might be some mild discomfort. And then these are the signs that there might be more serious discomfort going on. Go back, if they've taken some medication, go back and look at that checklist you kind of made in your head again, maybe an hour or two later, and say, do I notice any changes? Are they still breathing heavily? Do they still look uncomfortable? Have they relaxed at all? And that's going to give you a clear sign whether or not the situation has improved. And that tells you whether what you're doing is working. So feel free to use that both as a identifying pain tool, but also as an identifying whether you've successfully handled the pain tool. It goes both ways. So then we want to make sure that we're managing our personal biases. This is a spectrum again. I've had family members who based on family history have said, she always acts like this, it's nothing. Well, if it's impacting the behavior, then it's something, I've also had families who, like I said in the beginning, statistically, we're more likely as loved ones to overestimate our loved one's pain and think they need way more than they do. So we want to make sure that we're looking honestly at ourselves and our motivation, and we're also looking honestly at our loved one and considering what we're seeing and what we know of them, and trying to keep that personal aspect out of it. especially so when that agitation, that like crankiness, that irritability comes into play, often you as their family are the people they take it out on. I routinely hear that no matter how hard I try, I can never make mom or dad happy. No matter what I do, nothing I do seems to be right. They're hard on you, you know? And part of that is, the parent-child dynamic. And part of that is that they know that they can trust you. They know that you're going to love them and be there for them regardless. So you are a person that it's safe to unleash all of that frustration on. So part of this managing your personal bias is also managing your personal emotions. If you are spending time with them and they're really nasty, trying to take that step back and not take it personally and think maybe they're acting this way because they're in pain is a big effort. It's a lot to do in that moment where like you're really hurt because this person that you love so much and that loves you is treating you poorly. So try to take that step back. If it helps, I use the word behavior a lot in in this talk and in this slideshow, but for us, what we think of as expressions of distress, we don't call it behavior, we call it an expression of distress. And it seems kind of silly, but think about the mental image that it conjures for you when you think about the word behavior. Like technically, behavior is anything. Buying someone flowers is a behavior. Punching someone in the face is also a behavior. But overwhelmingly, and especially if you've worked in care fields, if you've been a teacher, if you've been in public service or retail or anything like that, particularly if you've got that experience, behavior tends to take on a very specific negative tone. And so when we think my loved one is behaving, we tend to think of it automatically in a negative light.
Yeah.
Whereas if we think of it as an expression of distress, suddenly that shifts the focus. It's still behavior, but it's not that they're behaving badly. It's that this is how they're expressing their distress. And that subtle shift changes the way that we think about it. Now we're not thinking about what they're doing wrong. We're thinking about what's wrong that's causing them to do that. Does that make sense?
Oh, yeah.
Okay.
Yes,
Yeah. So we definitely want to try to keep that clear head, which I get is hard. But it's very helpful. And then the last thing is that we want to make sure that we're careful about making assumptions. We've all heard what happens when you make assumptions.
Yes.
Yeah. Okay. But don't make me say it. Okay. Yeah. So it's kind of a tightrope walk here, because for our loved ones with dementia who can't necessarily communicate to us in a clear way what's going on, we have to make a certain amount of assumptions, but we also have to be careful about it, because even informed assumptions, even informed conclusions can be wrong and can impact treatment. And so the example that I think of most readily is like, if our loved one has chronic back pain and we know they've had it for years, when we see them in discomfort, we can reasonably assume it's probably their back. But constipation also causes back pain. And kidney pain, like from a urinary tract infection, also often causes back pain.
Mhm.
And so we might overlook a potentially serious problem because we've assumed it's the most, the most obvious answer. And that's a weird thing, because usually the most obvious answer is the correct one. So when we find ourselves in a situation like this, again, we want to make sure that we're using those observational skills and that we're kind of checking our work, so to speak. So if you know your loved one has chronic back pain, you might also want to check and see, like, pay attention to how frequently they're going to the bathroom. Is it more than usual? That might be a sign that there's some kidney pain. If they're if they're going to the bathroom really frequently, or if they have to go, but they're struggling to go, stuff like that, like classic urinary tract infection signs, oh, maybe I should, like, we're still going to treat the pain because they are still in pain, but maybe we should also get a urine screen done. Constipation is a huge one with back pain. So a lot of the stronger painkillers cause constipation. And so if we assume that it's back pain and we give the Percocet, but it's really constipation, the Percocet is going to make the constipation worse. And what are we going to do? Give more Percocet. And so it creates this negative cycle. And so it's not necessarily a pleasant thing, but we have to be monitoring for bowel movements after giving a medication like that, just to make sure that we're not misreading the signs. So it's just kind of a tricky situation to watch, because just like you can have a cough with a cold or a flu or lung cancer, like it's a spectrum. A cough does a lot of things. Back pain does a lot of things. Most pain can be a lot of different things. And so we want to choose the most obvious answer because that's usually right, but we want to check our work and make sure that we're not overlooking something that might become more serious. Constipation can be very dangerous if it goes on for too long. Kidney infections can become very dangerous very quickly and turn into sepsis, especially for seniors. So we want to make sure that we're paying attention to those things so that we can avoid a bigger problem. So, questions about any of that?
I think if you didn't use the observation skills, I know I would take my mom to the doctor and she would say she was fine for every question he would ask her. And I would, I knew that wasn't true.
Mm-hmm.
But I think from minute to minute, they might not remember that they even had pain unless you asked them right at the right moment. So that's where these observation skills are really good. So is it, do you observe for like a week or I guess it depends on what kind of behavior they have, how long you watch something to see if you have to make a move on it. Do you know what I mean?
Yeah. So I would say it kind of depends on the situation. So, for the most part, when we use that tool, we're looking at a snapshot. We're looking at this moment in time. What do we see right now? But there's a reason that we did that. Mm-hmm. So it might be that they fell and that's why we're looking what's going on right now. It might be that they complained that something hurts and that's what we're looking at right now. It might be that their behavior seems a little off and that's what we're looking at right now. If the change is more mild, like something seems not quite right, but I can't put my finger on it, kind of a thing, you might want to think back over like, okay, the last couple of days, what seems different? So it kind of depends on the situation. You're right. But it really can be like that snapshot tool, because you're right. Like they are masters of mindfulness. So if in that moment they feel okay, even if they were in terrible pain 10 minutes ago, they're not necessarily going to
remember. Yeah.
And another part of it that comes into play, particularly with this generation, is that they're very proud and they don't like to share that they're struggling.
Right.
So the other part of it is that they might know that they're uncomfortable, but they're not going to say it because they don't want to put forward that vulnerability. So we've really got to be paying attention. But yeah, it's definitely tough.
Yeah.
Okay. And I think Linda, it looked like you had something you wanted to say too. Did you have any questions or comments?
No, I'm good. Thank you.
All right. So anything overall, thoughts, anything else you want to talk about? Anything else that you want us to talk about in the future?
I guess the one thing that we have found with our mom is she seems to be prone to UTIs. Mm-hmm. And it's probably from wearing the Depends.
Mhm.
And normally when you have a bladder infection, it burns when you urinate, but yet she never complains of pain.
Mhm.
Never. It's like we catch it when we find that she's urinating a lot and having more accidents. So that's frustrating.
Yeah, it's really strange. The symptoms of urinary tract infection change over the course of our lives. I don't know why that is, but they do. So like for a young healthy person, like you said, that frequency, that like the constant urge to go and then maybe not being able to go, and that burning and discomfort when you go is usually our first sign that something is up.
Right.
For a senior, usually the first sign is a change in mental status. Usually the first symptom is that they just don't seem like themselves. We
Yep.
may see more incontinence, like they're having more accidents, they're burning through more Depends, they need to change their clothes more frequently, things like that. We definitely also see, so we know that that urgency is there. We know that that increased urination is there.
Mhm.
But most often it's the confusion that we notice first.
Yeah,
Yeah.
that happened to my dad, and he would go in his dementia unit, he would go to the wrong room. The aides would pick up the people who served him meals would pick up right away that, like you said, he was off.
Mhm.
So yeah,
Yeah. And
that's how, yeah,
yeah. And it's strange because we can't use that alone as justification to do a
right,
analysis, because especially, with dementia, they're a different person sometimes from moment to moment. So we can't just say a change in mental status. We also have to be looking for those other things to justify, ordering
Right.
that urine test. And also just putting them through the discomfort of doing one, because, peeing in a cup is nobody's favorite thing. So
right,
just truthfully, and it's not like you can wring out a Depend, so because it's gonna mess up your sample. You know, so but if we see that confusion, we definitely want to make sure that we're looking for what else is off here. And communicating that to the doctor, to us, to whoever, so that you can get that testing done and find out. And one of the best things that our loved ones can do, and this is again, what is our loved one willing to do, becomes a barrier here. But if our loved one does get frequent UTIs, the best thing they can do is stay hydrated, but often
Yeah.
with light, because they don't want to
Right.
drink. They don't feel that they need to drink. And even if they do drink, they don't necessarily want water. And that's and
Mhm.
that's challenging.
Right.
Any other thoughts or concerns?
No, thank you. It's very, very detailed and very informative.
As always, thank you.
Well, thank you.
Yes.
I'm happy to help. Did either of you have any ideas for a future topic you'd like to discuss?
Nothing
At the
comes.
moment,
Okay, so I'm thinking, barring anybody coming up with a suggestion that's more immediate. So when I send out the recording, other people might have ideas. But barring that, I'm thinking what I'm going to talk about next month is probably like when conflict arises in care. Because we've touched on it here and there in different talks, but I really want to focus on that. Like, how do we fight with our loved one less? How do we make the best of it when we have to fight with our loved one? And especially, how do we, as caretakers and caregivers of our loved one, manage the emotional toll that takes on us? Because it is incredibly difficult to watch your loved one go through this and to be doing everything in your power to help them, and to still have them not understand it and not appreciate it, and sometimes actively punish us for it. It's just a really challenging dynamic, and I see a lot of our families struggle with it. So I'm thinking that's probably going to be our topic for next month.
that'll be a good one.
Yeah.
Yes.
I really hope so. But if you think of anything in the meantime, feel free to shoot me an email or give me a call, and I'm happy to change gears if something more pressing comes up.
Okay,
Okay.
Well,
Thank
thank
All
you.
right.
you.
Well, thank you very